Right. So I will not take up the time like you can ring your bell, but whether I move or not, that's a different thing. So, but inshallah, thank you, Vandesha, Akhtar, for your kind invitation, and Novartis for asking me to come in for this discussion. All these slides have been prepared, and I've been asked by the Novartis. So this is the disclosure slide, basically. Now, um, heart failure is on the rise because of two simple things. Number one, the population is increasing. And number two, you're doing something because of which the infant mortality went down, and then because of which the expected death, which was supposed to happen at the age of 45, 55, etc., did not happen. So the LV kept on pumping. The one who was not supposed to be living is living, so to speak. Not that we are playing gods or something, but that's the way it is. So the things, the way they happen, unfortunately, yes, we are of course killing enough also, but that is the way it is. So what has happened is that your numbers have gradually increased. Is the pointer gone, sir? Yeah. Right. So I don't think the pointer works. So the number has increased, and now the pointer is on. So as it is, from in 2010, you had a 2.8, and now it's at 3.5 million people have been affected. What light है वो उसको बताते नहीं. This one is there. Okay. So as it is, it has gone up, and the things has been kept on increasing. Now, जिस वक्त हमने पढ़ना शुरू किया था ना medicine, so the way it was explained to me by my teachers was that this heart failure business is so deadly that in 5 to 6 years, all are gone. But now, of course, as you said, Shahbaz Saab, that we are fighting the battle. We are trying to come up with it. But the thing is that now again, after a couple of years, 5 years down the road, still plenty are living. But of course, the real battle lies somewhere over here, in the very first part, the very first year, where you don't want them to suddenly decline. And that is why what he said was that you need to start all these medicines as early, as quickly possible, because this way, then your graph will hopefully drift upwards. And it is that what we want. Of course, these slides are basically designed from old ones that when you had something which was going in this direction and only a very small percentage of improvement was noted. If you notice from here that a heart failure business said that only at 1 year, 29% with preserved ejection fraction, and those with reduced ejection fraction, nearly 32%. So virtually 30% were going. Now, it said that as time progressed, after 5 years, it says that over here, 65, and then 68. Similarly, very, very near. It doesn't solve our battles. Of course, you all know that we all agree about these various numbers. But for me, the most interesting fact is this. Okay, गल नहीं, 40% है ना heart, ठीक जा रहा है. This is the statement. Fikr di gall nahi, you are above 30%. Now, this is the thing that needs to be adjusted. We need to get our mindset corrected that no 30%, 40% is not what you want. You want the hearts to be at 50, 60, or preferably even at resting conditions, pumping at 65, 70. That is where you need them to be, because that is what will ensure that you can remain in functional class 1. No one likes the fact that you get short of the breath when you're climbing up the stairs. So everyone wants to do the right thing. This slide, I'm sure we have seen so many times, and you have all sort of memorized this thing up. But just for a repetition, neprilysin is the thing which degrades the natriureteric peptides, and there are plenty of them, the ANB, the BNP, and the CNP, and they all have their own potential benefits. So you want to make sure that this thing stays in your body as long as possible, and that's why this medicine sort of took off. And then the combination of neprilysin along with valsartan, after all, the sacubitril, inhibition, that thing took off again, and you have seen these slides again so many times that I don't want to further go into this one. These are your various trials, and as you can see, from the paradigm heart failure to the transition to the pioneer to the prove it to the evaluating heart failure, they all kept on saying that enalapril has now another person to compete against, and valsartan has gradually taken up, and you had other trials in which they are gradually improving and showed their certain benefits, and we have seen these trials and read about them. And of course, the Paragon heart failure trial, which had 4,822 individuals, and that also said that based on the previous trials, the potential benefits shown in the patient with left ventricular ejection fraction below the median as biological possibilities. So everything has always been in this direction, which said that you need to do something better, more, and that is the way you need to go. Again, the pooled analysis over here said that sequin valsartan efficacy varied by ejection fraction and was greatest in the patients with ejection fraction below normal, including patients with heart failure in the mid-range. But the thing in that heart failure paragon in the very last part over here, it says that the heart failure echocardiography sub-study indicated that 11% of patients and ejection fraction below the inclusion threshold of 45 suggested overlap, and with the paradigm heart failure population and the good representation of the mid-range of EF in the pooled analysis. For me, there's just one big challenge that I would like you all to think about and come up the answer with. These analyses, as they said, was coming out of echocardiographic evaluations. Now, echocardiographic evaluations, how they were carried out, what were the modalities in which they were done in, was this were they able to evaluate the mitral regurgitant volume loss also with it? Because these patients have all sorts of other combination things happening. Or did we actually were able to correlate these trials with volume-based analysis? And from there, we can have a better idea. So there are ideas and things in which there is still space where we can work on and get our CT people, our thallium people to have a look and decide that when you have these ejection fractions coming up, always look at your multiple analysis, multiple strokes, and from there you will have an analysis, rather than from a single beat. So the Paragon heart failure trial finally said that the hospitalization, etc., with the heart failure, it did make a difference. But as far as the death, etc., was concerned, there's not much difference over there. So now the gap in knowledge that was created was that where does the fact stand that you have all of these 40% and 45% ejection fraction improvements, you have those stabilizations, but when can you start this medicine? Should you start it immediately or not? So this is the reason why, despite all of these trials, there was this gap available in the knowledge, and they wanted to further look into this fact. So AHA guidelines recommended consideration of sequin valsartan to reduce the hospitalization in preserved ejection fractions and also in midriff. Paragon said excluded decompensated heart failure, but a post hoc analysis suggested a larger all-point relative risk reductions with sacubitril valsartan compared to valsartan in those, and it is unclear whether the initiation of sacubitril is safe and effective for individuals with ejection fraction of more than 40% who are stabilized following a recent episode of worsening of heart failure. We have all remember those diagrams in which you show that the patient has a worsening, drops down, stabilizes, improves back, but never comes back to what the person was prior to the admission. जो हमारी extended line हमारे यहाँ सारे house officers बोलते हैं, the patient was enjoying the normal health prior to admission. Now, what was that normal health? That is something that we really always wonder. So when this study was constructed, it was in multi-center, 100 centers were involved, double-blind, controlled study. Mainly, this was USA and Canada where this was done. 52% were ladies who were involved. in order to make it more diverse population, they had 20% blacks over there, but majority were the fair complexed people. Though they say that 1 to 3% were also from the Asian origin. So there is still plenty of things to be done. And of course, anyone above the age of 80 and over 40 was done. In this, they had a period in which they were able to include 466 patients, 233 in each group, so a small number. There was no cutoff and there was no run-in period like it was decided for your other trials that were done before. So these patients just came in and the medications were given and then they were looked in, and the analysis was regarding the pro-BNP evaluations at the week 4 and the week 8, and to see, and then later on to also further follow it up for 84 weeks. So this trial, which was the Paraglide, was published very recently, I think in the month of May, and also in the ACC and in the guidelines that came up. So this is a rather new study that is over here. So if you notice over here, this is the period which makes the maximum difference. This is the period where you have the maximum decline. And it is over here that the pro-BNP is being managed better. You get rid of more pro-BNP. Of course, there will be people who will say that, does that really make a big benefit in the long terms? These things have to be evaluated because there is this upper one which is sort of drifting down again. And in your next slide, you can see that at the EF of more than 40%, it is rather not that clear. But over here, as far as between 40 to 60%, it is quite well clear over here. Sorry, 60% over here. So things are murky. Now things became interesting, especially when this new term win ratio was introduced. I was not totally aware of it. Those of you who knew about it are better. And I have a small slide later on at the end. I hope Novartis will not mind to it. So there's a win ratio which was introduced, and the hierarchical outcome numericals were done, in which what they basically try to do is they have these two groups, try and make them as well balanced and then as much expected. So the idea was that if you are above 32, you are better. If you are below 32, you are worse. So this was what was being looked at. In the CV deaths, as we saw, not much of a difference, but it is this hospitalization part which actually makes a big difference. Now, we all, by and large, work in centers which are nationally sponsored, thereby saying they are government hospitals. And patients do not pay for the time spent in a hospital. कोई 5 दिन रह गया, कोई 10 दिन रह गया. In reality, each bed has a cost behind it. And my rough estimate, without medication, for a bed today in a teaching hospital is 15 to 20,000 rupees per day. That is the cost of keeping a patient inside. So when we keep patients just under observation, so it becomes a very tricky question. So from a national economic point of view, you all are well aware of the fact that now people are moving towards day admission. They want to cut down. The TEVI part is done as a morning case, comes in and then goes back. So all of this is the thing that you want to cut down in the cost as much as possible. And the cost cutting when you are done, the cost of the whole medicine is nothing. My first big experience with this cost-cutting business was introduced to me many years back when an elderly friend of mine, or more like a friend's elderly father, was in UK, and at night he had a cardiac heart block. And he was rushed for his workup to be done. He was 87 years of age. So they took him in, and unlike us, they just put in a permanent pacemaker. And in 2 days, the patient was home. I just then later on had a discussion with one of their consultants and asked, why this rapidity? They said, if we kept him in under observation for 7 days, each single day would have cost him 1,500 sterlings. So the cost of the whole thing, doing the procedure, and we all knew that he's in that age bracket, that he's going to need it eventually. So let's do it and get it over with. So this concept that we have about keeping our patients inside the hospitals for a protracted time, especially for a lot of things, needs to be reviewed. And you have to understand the size of the hospitals becomes uneconomical. And that is where the whole world is now moving to. So with the same thing, overall, it showed a certain amount of benefit, and there was an evidence of numerical difference in the subgroup. Okay, sir, here I go.
Take your time, no rush.
With subgroup with EF of 60% and pro-BNP, I was hoping I'll make it 15 minutes actually. In the pre-specified subgroup, EF was over here. So you have an initiative which showed a certain amount of benefit. And this is where, if you look at this data, you can see that the events and the number of patients with the sacubital valsartan was 71. 48 patients out of those 233 got affected. Over here, the number is different. The number is higher. So there is a substantial number of patients who did better. Urgent heart failure is your other business, which you don't like. रात को जो फोन आते हैं ना कि भाई का सीना खराब हो रहा है, कुछ मसला हो गया है. This is something that you really don't want. And this may be your ticket to help you out from there. So in summary, the exposure-adjusted incidence was of the severe heart effects was found to be 103, which was roughly the same. Sacubital valsartan group demonstrated lower incidence of worsening renal function and more symptomatic hypotension. My presumption of being less renal dysfunction is because the dosage of valsartan is less. Since the dosage of valsartan, and by the way, over here, patients were included irrespective of the ejection fraction. Even those who had an EGFR of 20 were included in this study. Those who had a BMI of 40, they were also included in this study. These things were the things which were removed from the previous trials. And the age group, of course, was not a thing to be looked at. But of course, more asymptomatic hypertension when compared and valsartan, and hyperkalemia was similar. And of course, when you're being well controlled, your tendency to become hypotensive was also high. So sacubital valsartan showed fewer hypertensive related severe adverse effects and compared with the valsartan group. However, the valsartan group also had more treatment related hypotension. So these are the things that you always will need to remember. Angioedema, I've just seen once in my life, and they also saw it once, so I'm happy about that. And safety data was collected for only 8 weeks, so this becomes the limiting factor. And they will have those longer 84 weeks data coming out later on. So among diverse population, the ejection fraction of more than 40% stabilized after a recent episode of worsening in the heart failure. Patients on sacubital valsartan saw a greater reduction in NT-proBNP than those on valsartan through 8 weeks. Now, I started observing that people start doing these NT-proBNP very frequently. You do your primary analysis and then forget about it. It is high. It is heart failure. It's going to take time to settle down. And come back after 4 or 8 weeks, do a repeat analysis for your own patients. Otherwise, when this thing keeps on going up and down, your patient starts getting disturbed and not happy. So exposure-adjusted incidence are found to be 103, which is not same, it's about the same, and patients treated with sacubital valsartan experienced low rates of worsening of renal function. So these are the things that were there. So for those of you who are slightly interested, I had this slide one out. What is a win ratio? The new approach to analysis. The conventional reporting of the composite endpoints in the clinical trial has an inherent limitation in which it is emphasis on each patient's first event, which is often the outcome of lesser clinical importance. To overcome this problem, they introduced the concept of win ratio for reporting composite endpoints. Patients in the new treatment and control group are formed into matched pairs based on their risk profiles. So this becomes a way of analysis. A newer way of analysis, we are not the statisticians, but I had this, made this slide out for the whole, for everyone to understand a little bit, and hierarchical positive are complex endpoint combining outcomes of different types and different clinical importance into an ordinal outcome that prioritizes the clinical most important, for example, most severe event of a patient. An endpoint can be analyzed with the win odds on adaptation of win ratio to include ties. So this is a new thing slightly. We will be coming across this part of the thing a bit more commonly. And once again, I would like to thank the organizers and Novartis for asking me to come in and do this discussion with you. Thank you.